Welcome to our podcast, Psychiatric Services from Pages to Practice. In this podcast, we highlight new research or columns published this month in the journal Psychiatric Services. I'm Lisa Dixon, editor of Psychiatric Services, and I'm here with podcast editor and my co-host, Josh Berezin. Hi, Josh.
Hi, Lisa.
Great to have you back.
Good to be back.
Yeah, we're very excited. All the listeners are very excited about your new daughter.
Thank you.
And we're glad that she was willing to share you with us today.
I'll let her know.
Yes. Okay, please do. Yeah, so today we have a special treat. We always have a special treat, but and as usual, we're departing from our normal protocol by actually talking about a series of articles that are protocols. And Josh will let you know all about Dr. Milton Wainberg.
So we're very lucky to have Dr. Milton Wainberg, who's the professor of clinical psychiatry and the director of global mental health implementation science at Columbia University, and also the principal investigator of the NIMH-funded Global Mental Health Scale-Up Hubs. Dr. Wainberg, did I get your titles right?
Yes, but that's correct. But it's one of the 11 hubs. I'm the principal investigator, just to make sure.
Perfect. So we'll talk a little bit about the hubs, because I think that those are a good entree into some of your work. But the reason we have you on the podcast today is because you are working with Psychiatric Services to publish a series of articles on global mental health implementation science protocols. And I think 5 have actually been published, and there's more on the way. So just by way of introduction, maybe you and Lisa could talk a little bit about how the collaboration with Psychiatric Services got off the ground.
Sure. So thank you so much, first, for the opportunity. Number 2, one of the things that sometimes we don't know in the US, where we still know that there is what we call the mental health treatment gap. There are a lot of people that don't have access to care. If you go to low and middle income countries, that gap is humongous. About 85 to 90% of people don't have access to mental health care. There are no resources. There's lots of stigma. So in general, people don't have access to any mental health treatment. There are a few people within psychiatry that have been working in trying to address this treatment gap in low and middle income countries. And NIMH got on board and has had 2 opportunities for funding to get those studies happening. So there was a previous one a few years ago, and then this is the latest one, where 11 hubs were funded in different parts of the world. And I happen to be the principal investigator with Maria Oquendo from UPenn in the one that it's based in Mozambique. These hubs, interestingly, have 2 portions. One is a scale-up research study, which is what these protocols that psych services are going to be are focusing on. But we also have a capacity building component where you work with 2 to 5 countries. Of course, we were crazy enough to try to work with 5 countries. So we are also working with Botswana, again with Mozambique in capacity building, South Africa, Zambia, and Malawi, which has been great because we have been able to sort of stimulate processes in other settings to do the work of implementing mental health services.
And when I learned about this work, because I really hadn't been exposed to much global research in my career. And I got to Columbia and I saw an amazing array of global work being done that really had the potential to make a difference. And not, I think as I learned about what was happening at Columbia, my eyes were open to what was happening elsewhere. And I thought, well, this journal is about psychiatric services, and that means psychiatric services everywhere, not for a particular disease, not for a particular person in a particular country. And so I had been looking for ways to more systematically bring global research into the journal. And what is so amazing about this series, and I really, really hope that our listeners will take a look. But what I really liked was that Milton wanted to publish protocols. Now, For those of you who are not researchers, the idea of a protocol really doesn't sound very exciting. And I have to admit, just a straight protocol is not very exciting. In fact, it's tedious and boring. But the protocols have the essence of the thinking in them and the design and the potential. And so Milton and I talked about how to take these boring protocols. And I mean, it's not that the work is boring, it's just that the document is boring. And
so far, Lisa, this is a very soft sell.
Okay. But to take them and make them into something that lives and breathes and that will help our readership understand not only what the goals of the study are, but how we got there and how it's really a version of implementation science for the psych services reader and sort of taking these steps in implementation science and making them transparent and clear. And I mean, I could go on about why I think this is so important, but Milton agreed to work with, correct me if I get this wrong, Milton, to try to encourage and motivate all of the hubs to come to work with the journal and create the implementation protocols that would map to a somewhat different format that would be easier to digest and more transparent for the non-researcher and for the researcher.
Yeah, it was very serendipitous that as you were thinking about that, we were meeting all the hubs, and I told, before talking to you, I wanted to publish all the protocols. And the reason for that, number one, to make readers understand that what they don't see, they don't know about, the treatment gap in parts of the world. Actually, 90% of the population of the world are in low and middle income countries. So you're talking a treatment gap in the majority of the world. And so when we were all, we would meet once a month, and I said to them, let's try to publish all of them together. We went to several journals. I contacted you, I contacted others, and not too many journals were interested, I have to say. I don't know if you want to tell that to the audience. Maybe I didn't see it. It was because of the boringness, the boring protocol format issue. I love that you and I thought, okay, this is not about having the perfect protocol, which, by the way, was a problem with reviewers because some of them wanted exactly protocols the way protocols get published. The idea was not just to have a protocol, but to make meaning out of publishing these. And also because implementation science is not so much of a well-known science. We tend to publish much more efficacy trials and effectiveness trials, and to bring research to practice. It's complicated, very complicated, much more complicated than doing it in a lab where you have perfect control of everything. I can tell you that in my study, we have had 2 cyclones and COVID that makes everything change dramatically. And you can still have, changes on government, which means that you need to make sure that whoever you're working in government is still connecting with you and what you need to do. But by the way, that would happen here in the US too. This is not just an element of low and middle income countries. So there's some important challenges, but it's the only way that we can really get treatment to populations that don't have access. So I love that you work with me in trying to make something that would be, appealing for the audience to read. It was not easy to convince the group to, because everybody just wanted to put a protocol. It's much easier, right? They already had it. So it took us some time to convince the whole group. The good thing is out of the 11 hubs, 10 provided protocols, and some of them are still under review. And the challenge was that we needed to make sure that everybody would understand the format that you and I thought would be both showing a protocol, but at the same time demonstrating something of interest, and putting something out there. I also think that because in psychiatry, we tend to work so much in silos, I thought that it was very important to perhaps understand all the interdisciplinary activities that happens when you do implementation science, both in the US, but much more in low and middle income countries. The amount of task shifting that needs to happen, in other words, that because you don't have resources, you have countries where you have, 0.002 psychiatrists per 100,000. So it's like there's no resources. There's no way that we can wait for psychiatrists and psychologists to be trained to do the work. So there's a lot of training done mental health specialists at different levels and figure out how they can participate. There have been very good studies previously that have shown beautiful efficacy and effectiveness. So the idea that NIMH decided to put money for these trials, that let's expand, scale up, and see how it works. I thought that it was wonderful for all of us and for science. So you will
So
see.
Milton,
Yes.
just to jump in there, when you were describing the conditions in low and middle income countries, and now when you talked about the lack of access to services in many low and middle income countries, I think we need to acknowledge that we have a not dissimilar problem in the United States. I'm not saying it's quite as horrible, but we have very inequitable access to services in our country. And so I think, very concretely, there are many lessons that can be learned and taken from what is being done in the hubs, in the NIMH hubs, and take them back to the United States, as you are actually already doing.
Thank you. You're absolutely right. The idea of trying to bring how we do these science to the US is crucial because we have a treatment gap here, and we have not at all solved the problem and how to provide care to the population. So there is a mental health disparity enormous in the country. We've seen it even worse during COVID. And we've also seen how people with mental illness, any psychiatric disorder, are more prone to get infected, more prone to be hospitalized, and then more prone to die, which talks about the comorbidity of mental illness yet again, with another illness being the worst comorbidity to have. And by the way, it's not among the criteria to be vaccinated. It should. We have hypertension, yada, but somehow we always forget about mental health. So, that silo problem of mental health, it happens everywhere in the US and abroad. In countries, for example, where, some of the difficulties that we handle, sometimes this was the first protocol that an IRB was dealing with mental health and implementation science and effectiveness at the same time. And there was not even a mental health person in some of these IRB places. So to get IRBs to approve this was also, which I think is fantastic, educating IRBs about the work that needs to happen. Because initially they are very, appropriately, they want to know the ethics. They want to make sure that we're doing the right thing. And they carry all the stigmas that we all carry, because we all have stigmas inside of us. But it was also a great opportunity to begin the process of capacity building within the ethics world as we impart, this crucial need of doing implementation studies in countries where there's a lot of need. And you're right, bringing to the US, we are doing that. I have to tell you, sometimes it's easier in a low and middle income country when you have a small kitchen where the chef, who brings the food, who serves the food, you can put all of them in one room. So sometimes, because we're so structured in this country, and also we have learned to divide substance abuse from mental health and drug abuse, from funding perspectives, from, policy perspectives. That even makes it even more complicated because, for example, in my study that we deal with all disorders, if I would have to do it here, I would have to talk to so many policymakers that are in different parts and have different visions. Whereas in Mozambique, I was, there are 18 psychiatrists. Well, when we started, there were 14. I knew 11 of them because the other 3 were in Portugal finishing their training. And I knew, the vast majority of the psychologists working in the ministry. So the decision making, which doesn't happen with me because this is totally a partnership. In implementation science, you work with policymakers, because otherwise the words that I have a T32 postdoctoral fellowship, and we have a couple of Fogarty grants in capacity building implementation science in Africa and in Asia. And I always tell people there are 3 words that you need to remember in everything that we do, which is sustainability, sustainability, and sustainability. So the work that we do has to be sustainable. We're not trying to do studies to prove that something is effective. We're trying to do studies that something can be implemented in a sustainable way. Otherwise, we're wasting effort and money, because at the end, when the research funds are gone, the plan is for whoever is in place locally can continue with it without funding. Obviously, it would be great to have more funding. So let's not try to take away potential sources of funding for very, very poor countries. But that's part of the goal of these studies. Yes.
What do you think some of the other overriding themes are when you step back and you look at the 11 hubs or the protocols that are being published now, either in terms of the challenges that are faced or the kind of sort of solutions that people are coming up with, or the things that people are targeting? What are some overarching themes that have come up in this work?
It's a great question, Josh, because number one, all of them have the idea of implementing something that hopefully will be sustainable. The beauty is that there's a combination of implementation strategies of how to do it and with whom to do it that it's incredibly interesting. Some of them, for example, deal with prevention of suicide by working with the community, and doesn't even require much, mental health in many ways to be directly doing anything, because it's about preventing and taking away sources of, what people use to kill themselves, the most common ones, and how the community and policymakers get involved in that. And then there are other studies that are doing one or two disorders that are the most common, and because it's the comfort level of whoever they're working with. And then, I have to say that my study is a little crazy. We were working with the Ministry of Health, and she's one of my fellows in, which is also very interesting, right? The way it all started, I have to tell you. I went to do, I'm an HIV psychiatrist before I became a researcher, so 400 years ago. And so I went to do a training on HIV and mental health because I speak Portuguese and I had been working in Brazil, and I was trying to figure out if I could work in Mozambique, because I knew there was a very poor country. And even though there's HIV funding from multiple universities, including Columbia University, nobody has worked with them in mental health until that point. So I met with them. I went to do a training, and there were 14 people in the room, and one of them was the director of mental health in the Ministry of Health. And when she introduced herself, Lydia Govea, a good friend now, I turned around and was like, did she say that she's in the ministry? It's like, yes. It's like, I said to her, listen, I've never been in this situation that I'm training the highest ranking person in the country in mental health. So if you don't mind, we can have coffee or a glass of wine or dinner, and perhaps 20 years of work together, because I want your grandchildren and my grandchildren to be good friends. So that was an introduction. It was funny, but I knew that Mozambicans by then, I knew their flavors, that they are on the funny side. And Lydia was one of my students to get a PhD in Brazil. Complicated story, but we have funding from Fogarty, which is one of the capacity building arms of NIH to do international capacity building. And of all the fellows, she couldn't come up with a plan because she's in charge of mental health. She cannot do like, let's look at depression, in perinatal. What about the non-perinatal? What about the psychotic women? What about women with psychosis? And so I sat down with her, and she wanted to do a study of expanding mental health to 70% of the country. a small idea. And not only depression or alcohol, it was all disorders. And I have to tell you also that we in the US don't know this. In most of these countries, psychiatrists actually are neurologists. So they treat epilepsy. So we are expanding the system from cities to rural areas in all disorders in psychiatry and in seizures, epilepsy, which is absolutely crazy, but amazing. And it all came from her, I have to tell you. The research question, it was not my research question. She had a problem that she needed to solve, and together we come up with a plan, and that's why we have this study that we're doing.
Well, one of the things that's great about the papers is that you've the two of you have put in these boxes that have advantages, challenges, and then design solutions. And it's just fascinating to look through those just those boxes in each of the papers and see what is sort of the same and what's different. And you really do see what you've mentioned is that relationships with people in the ministry or agency that's overseeing mental health is often in one of the advantages. And the other interesting thing is to think about design solutions. Just that idea is something that you don't, I think, see a lot in other papers, that you are really thinking through, okay, well, this is the situation we have on the ground here. We have to figure out a way around this. And that might be the quality of the roads in a country. It's not necessarily what we might think about in the US.
I agree. That was, I remember that phone call that, Lisa and I were talking about how to do these protocols. And the idea was precisely that. Let's have something to teach with this, not just what are lessons learned, what are things that were important, what were the challenges, how did we solve them, and and next steps, which is how we're supposed to end all of these papers. Like, what are the next steps with this? So that made the papers much more exciting. And even though people were having a hard time because they had to do more work, they all realized, at the end, nobody that wants to do more work, but they all realized that they got excited. The 11th that didn't come in is because they had already published a protocol. So it was not appropriate for them to write it again. But all of the others got very excited that it was important to, to bring forward, the challenges, the designs, and what to think of the future, and the value of what they were doing, which is super important.
So maybe just to make things a little bit more concrete for listeners, could you just give us a little bit of like an overview of what the studies are about, what they're actually doing at some of these sites for some of the papers that have already been published, just to give people a little bit more of a sense of what the actual work that's being done is on the ground?
Sure, absolutely. So there's a work in Pakistan, in rural Pakistan, working with teachers who have technology to address depression care within schools. It's a group that has been working very beautifully in other activities. They did perinatal depression prior to this, and so they decided that adolescence was the next step, and that's one of the trials. Then for children in Ghana, they have multifamily groups where they're working with caregivers to try to improve the psychiatric symptoms of young children. Amazing work. Then there's also work in West Africa trying to address adolescence and use a little bit work-related activities to empower adolescents in their lives, as at the same time they're providing them with care, with mental health care. And then there's also the other one. It's in Malawi, that it's addressing, they have done prior work on integration of depression care within HIV system. So they expanded it to do within any clinic treating chronic disorders. So they transfer what they had created before. What we're doing in our study, that I know that it sounded a little weird, 70% of the country, we're not working with 70% of the country. We're working in one large province that only has about 8 million people, depending on the day that you count how many people are there. There are different statistics. So our study is trying to understand, do we provide, because there's previous work that has shown that community health workers can treat some disorders effectively. So we're trying to figure out, do we do it by community health workers, do primary care providers in clinics, where there are no mental health providers? And by the way, even the primary care providers are not doctors. They are medicine technicians. You have to understand that in many of these countries, the workforce is really limited, even in total healthcare. And the countries have had to have done task shifting to begin with for healthcare, because otherwise, for example, HIV in Mozambique can be 9 to 19%, depending on the province. So we're trying to figure out who should do the work. We also, mindful of that, when I met with the director of community health workers of the country, I asked him, how many questions can a community health worker ask? Because these people who are in the bottom of the totem pole, they get paid a penny and a quarter for the work that they do, and they're part of the community and they know the community. Everybody wants them to do everything. He said, if you can ask 3 to 6 questions, that would be good. So we work very hard in trying to figure out, how do we develop a screener, validating first all the screeners, and then we developed a very interesting method, and actually it's going to be published in Psych Services too. So this is a podcast for both. We call it the Mental Wellness Tool. In Portuguese, it's called FICABEM. So the name came from them. And it's, with 3 questions, a community health worker can ask you first about every adult in the household. We don't have yet for adolescents, we're doing it. about their mental health questions, that these are valid 3 items, and with 73% sensitivity, then we know that we have to go and talk to another person, that it's positive. And with 94 sensitivity, with 3 questions only, we know that we need to ask 9 more questions and then be able to triage them to care. So we really simplified the method of assessing and triaging with no more than 3 plus 9 questions if needed. And that, we were hoping to do it, and we were impressed that we were able to do it. And I have to tell you, we're trying to bring it to other countries because it's a very easy and simple way of quickly determining cross-sectionally what's happening with you. And we put it in technology, so there would not be a need to, it's very easy for the health worker to quickly ask the questions and get an answer and move in to then applications to provide care or refer for higher care. So we try to, for the sustainability, and never everybody would think, well, technology is expensive. Yes, it's expensive at the beginning, but it's something that stays. So even when you train people and you come up with methods to train that use technology, which is what Lisa is also doing here in New York State, you do maintenance at the same time because you don't have to reproduce everything over and over again. So we added technology as a way of investing initially, yet having sustainability and being able to immediately collect data, know red flags. A supervisor knows immediately when somebody has a problem. We can also determine the fidelity of the work. You will see that in our paper, and the Pride paper, because when you use the application, there's an amount of time, like a mean number that of minutes that you should be in every frame. And if you spend double, then I can quickly go to you and say, Josh, let's talk about this. You're having, constructive, what's happening with this? You get stuck in this all the time. Can I help you there? Or if it's going too fast, let's go back and see how you're using. So there is an automatic method of looking at fidelity of the use of the application, which is connected to the use of the evidence, because we created following evidence. So it has been very exciting to create all of this. It has taken a lot of work and a lot of effort, but it has an impact that stays. So it's very sustainable at the same time. So that's what we're doing.
Well, I think it's a great example of why the papers are so engaging. They're anything but dry. You have task to treat 70% of a population where they're in a country where there are 18 psychiatrists. Go. And all the papers really are, how would you even start thinking about that? What's the first step? What's the first barrier? How do we get over that barrier? And how do we study it? And as you've mentioned here, how do you make it sustainable? So all of the papers that are in the series really are ways to get into the minds of people who are trying to solve these incredibly complex problems. And they are engaging, and they're the problems will be maybe more familiar than people might think.
I wanted to share something because I think that we in mental health have to be bold. And what you just described is like, whoa, this is huge and bold. But if we think of the huge epidemic that we've had of mental health, where 1 in every 4 people in the world has mental illness and there's no care for them, that's an epidemic. Where if you think 25% of the world has a problem, when we had those numbers for HIV, and I come from the HIV world, we had PEPFAR, we have funding, and we were bold. We decided we need to prevent death, and obviously death, but we still are doing, because now we can prevent illness and we can prevent other things. And we don't have that boldness in mental health. And I think these papers are bold and we should get stimulated to be more aggressive in what we propose to do, because it's needed, not just because we want to be doing it. It's because there is a huge need. And now with COVID, I don't have to tell you, because we know very clearly that the rise in mental health disorders is enormous, and we're going to continue having it because we're not there. And just to make it even more complicated for low and middle income countries, in Mozambique, they're not going to get the vaccine for 2 years. So we hear, it's very uncomfortable, I have to say, sometimes, because I'm in meetings with people that don't have access, and I have access to the vaccine. It's very sad, It's the same, I'm feeling the same way that I felt when I was doing HIV and there were no antiretrovirals in sub-Saharan Africa and I was collaborating there. I wish I can do something to improve that. It's not but we can scream. But the gap will be worse because there's going to be more problems, both here in the US and abroad. So we need to be bolder. We need to be more, we need to do things like this that are bigger and they look crazy. But if they can do them in HIV, why couldn't we do them in mental health?
So let's leave it there. Read the papers, be bold, save the world. Dr. Milton Wainberg, thank you so much for joining us.
Thank you.
Thank you so much, Liz and Josh. It was wonderful to talk to you.
Wow. I love the parting shot of an invitation to be bold. And I really appreciate that, Dr. Wainberg. That's it for today. We invite you to visit our website, ps.psychiatryonline.org, to read the articles we discussed in this episode, as well as other great research. We welcome your feedback. Please email us at psjournal@psych.org. I'm Lisa Dixon.
I'm Josh Berzin.
Thank you for listening. Talk to you next time.